So our next presenter is actually a program change. The title was a little bit wrong in your program for what the topic is on. But our next presenter is someone who I think most of us within NMTRC know well. Genevieve Bergendahl is the clinical coordinator for NMTRC. But in reality, she has a much bigger job than that. She has to keep Giselle in control. And for years, she has been the one that keeps Giselle on task, on target for all of us, which is all by itself a great job. Genevieve is actually going to talk to us about the new concepts for DFMO and Velcade, which was not listed in your program. You are this one, I believe, right?
Good, great. Well, thank you for having me. This is so nice to see you all in person and not just over WebEx. So I feel like I've become a voice to you and not a face, so this is nice. So good. I'm going to talk today about our phase 1/2 trial concept for DFMO in combination with Velcade that we're hoping to put through our pipeline this year. So here we go. And thank you, Andre, for starting this up. So a lot of this has to do and sort of piggybacks on the back of a lot of what Andre was talking about. So some of it, we had a few of the same slides too, which is nice because it gives us a little, gives you a little intro. But here you can see that the polyamines that Andre was talking about increase ODC, increased polyamines lead to proliferation and oncogenesis. If you can decrease the polyamines, then you can promote apoptosis, and DFMO blocks ODC, which is the pathway for that. So that was the basic concept for DFMO in the trial. And Andre showed you this slide, but for us, what I wanted to point out was that we had a very interesting response in our phase 1 study with DFMO, that the PET scans showed a reduced uptake, which we believe is decreased glucose metabolism, and that's the way I'm going to talk about it. So Andre talked about it a little bit for DFMO, but so how is glucose metabolism related to cancer? And in this scale, you can see there's an axis of Lin28 and LET7. When you have high Lin28 and low LET7, you shift the axis towards oncogenesis, overgrowth, and glucose metabolism. And if we can shift the axis the other way and get a high LET7 and a low Lin28, we can hopefully lead to some differentiation, some tumor suppression, and some growth retardation. So that is the hope there. Let's see, and this is a complicated slide, but what I really want to touch on is we all know how important MYC-N is in neuroblastoma, and this pathway is important for MYC-N. So the take-home message here is that LET7 has, I don't have that little, do I have it? Thanks, Don. So here we see LET7 has a direct pathway on blocking MYC-N amplification. And so again, we're interested in shifting this balance to decrease Lin28 here and increase LET7 so that we can block the MYC-N amplification. Okay. And so, our question is, can combinations help to decrease the Lin28 and increase the LET7 and shift the axis even further? In our lab here, we tested multiple combinations, and we found that Velcade had a nice synergistic effect in all of our cell lines. And so the interesting thing about Velcade is it decreases NF-kappa B. It also decreases IL-6, which also helps shift that axis. So we have a nice synergistic shifting of the axis and decrease it in all cell lines. So we thought that would be a nice combination to add to DFMO. And again, Andre showed this, although without the nice rotation. I had to one-up you a little bit. So, and he basically explained this, but from another perspective too, the PET response, as you can see in the combination, has gone down greatly, so decreasing glucose metabolism there. Okay. And so, in conclusion, in published papers in neuroblastoma, we know that neuroblastoma has a natural high state of high LIN28 and low LET7, and we know that suppression of LIN28 decreases MYC-N amplification. And in Gene Gerner and his team at Arizona, in their published papers in colon cancer, and I'm sorry, that color is coming up different here, so it's harder to see, but DFMO suppresses LIN28 and it increases LET7, resulting in decreased glucose metabolism. And in our lab, we've seen that DFMO suppresses PET activity and glucose metabolism. So our hypothesis for this study is that DFMO in neuroblastoma suppresses MYC-N and LIN28 and therefore suppresses glucose metabolism and causes a state of decreased oncogenesis. So that brings me to the fun stuff. My fun stuff is the actual trial concept. So we're looking at DFMO in combination with Velcade. It's going to be for relapsed and refractory neuroblastoma patients. It's an open-label trial, multi-center study, and so subjects are going to be in one strata, multiple relapse neuroblastoma. They'll be given DFMO for every day of a 21-day cycle for 2 cycles. And after 2 cycles, we'll start the Velcade. Velcade will be given on days 1, 4, and 8 of every 21-day cycle. And here you can see the treatment. So for cycle 1, it's DFMO alone. All patients will be started at 1,000 milligrams per meter squared twice a day for each day of this cycle. At the end of the cycle, we're going to check urine polyamines in real time. Depending on the urine polyamine response will depend on what dose the subject is given in the second cycle. So those who are having good urine polyamine responses will continue on the 1,000 milligrams per meter squared twice a day. And those who have not shown a response will increase to 2,000 milligrams per meter squared to try to get a response. We'll then check urine polyamines again at the end of cycle 2, and this isn't in here, but we've talked about then this group, again, if they're not responders, having the chance to go up to the 2,000 milligrams per meter squared again. And then in cycle 3 and 4, adding in the Velcade, so they'll receive their dose of DFMO, the same on every day of the 21-day cycle, and Velcade's given at 1 milligram per meter squared IV push on days 1, 4, and 8. And then, as with all of our trials, maintenance cycles. So anybody who's doing well on the trial, they're tolerating it, not having any progression, can continue on. We don't ever stop subjects from receiving something that's helping them. So, and then here, I just wanted to point out, this is what the tablets look like, of interest to everybody. So this was our first subject that on the phase 1 study, a picture of their bottle. And so the phase 1 endpoints will be safety and tolerability of DFMO in combination with Velcade in the first 6 patients. So because we have not used DFMO in combination with Velcade, we had to have a phase 1 portion first where we look at the safety of the combination together. We'll also be looking at the safety and tolerability of a DFMO dose of 2,000 milligrams per meter squared in the first 6 patients that are assigned to that dose. Our phase 1 study went up to 1,500 milligrams, so this is a dose just a little bit higher, and so we do a 6-patient safety cohort for that. And so then the overall primary objectives of the study to determine the safety and tolerability of DFMO as a single agent and combination with Velcade, correlation of urine polyamine levels with progression of disease in neuroblastoma, and then to evaluate the activity in the phase 2, it'll be evaluate the activity of DFMO as a single agent in combination with Velcade based on overall response rates and PET scans. So, PET scans is something we, at the start of my talk, the reason that we're really interested in this, and so it's not something that's been looked at in neuroblastoma as thoroughly, but has a very interesting response in our phase 1, so we'd be interested in looking at it in this phase 2. And also based on progression-free survival. We also have secondary objectives that have a lot of biomarker studies, so blood biomarkers for LET7. If they're having a standard of care tumor biopsy done, collecting some of that tumor to measure for LIN28 and ODC, effect on polyamine depletions, Something that we're adding into our NED study is circulating tumor cell analysis, so looking for circulating tumor cells in the blood. ODC activity, genomic analysis of cells pre and post treatment, and correlation in vitro response and in vivo response in our lab. Again, looking at flow cytometry like we do with all of our patients for tumor burden in the bone marrow. And then immunohistochemistry of bone marrow samples for a bunch of different biomarkers. So really looking for what we're seeing in this study. And then biomarker development, which I think a lot of studies are heading towards to target the drug to the right patients. So which patients is this drug really working for, and trying to find that out. And then to determine the dose effect of DFMO on biological correlates. And our response will be evaluated at the end of every 2 cycles with a CT and/or MRI, so whatever is used at baseline, PET scan, and then bone marrows if positive at study entry. And here you can see the flow of the study, what I just explained. So initial evaluation, they'll get their DFMO twice daily for every day of a 21-day cycle. One group will go on to receive another cycle of 1,000 milligrams, and the other group will go on to receive 2,000, depending on their urine polyamine response. We'll get to the end of cycle 2 evaluations, and they'll start Velcade. And then continue protocol therapy and have evaluations every 2 cycles. And that's it. It's exciting.